Hello, everyone, and thank you for joining us for today's Roundtable. I'm Dwayne Wright, Senior Research Analyst in Healthcare for Bloomberg Intelligence, which is Bloomberg's in-house proprietary research service. We do equity and industry-level research, and I'm part of a team of analysts in the US and abroad. I am excited to host our conversation today, Achieving Health Equity for All, a Solutions Roundtable. As we all know, long-standing health inequities have been exacerbated and exposed during the COVID-19 pandemic. The disproportionate health impact on people of color and those in geographically underserved areas cannot be ignored. Neither can the lack of access to care, biases that exist in healthcare, or the role of one's environment and its effect on health. The events of the past year has encouraged overdue conversations on the impact of systemic racism, bias, and other factors that impact our well-being. Improving health and well-being for everyone is both a moral and economic imperative. And all stakeholders in the healthcare system must find innovative solutions in addressing health equity. During today's roundtable, we will hear from various thought leaders as they share strategies for improving health equity and actionable steps that can be deployed today. We will explore the potential of public and private partnerships in advancing health equity, as well as the latest strategies, technologies, and tools. Before we begin the program, a few housekeeping notes. This is a virtual event, so please bear with us if we experience any technical issues. If Zoom crashes or you get disconnected, try to reopen the application, refresh your browser, and log back in. If you have any other web pages open, go ahead and close those now so we can have maximum bandwidth for this conversation. And we want to keep this as a conversation. If at any time you'd like to chime in on a topic, go ahead and raise your hand using the raise hand feature. At the top of your Zoom window, you'll see a raise hand icon. You can go ahead and click on that, and we'll make sure you are put into the queue. If you're not speaking, go ahead and mute yourself. And I know we've had a lot of practice, but don't forget to unmute yourself if you get called on. We want to make sure we hear from everyone on the panel, so be mindful of the time as you share your thoughts with your co-panelists. But before we get started, I'd like to introduce Dr. Kaleni Gabreas, U.S. Health Sector Leader for Deloitte Consulting, for opening remarks. Deloitte is sponsoring today's virtual roundtable. Kaleni?
Thank you, Dwayne, and thank you all for actually being here. I'm really looking forward to a great hour of discussing a topic that's near and dear to my heart, which is health equity. And I think that we have a historic time when most business leaders actually want to do something to advance health equity. Before we dive into deep, I just wanted to take a moment to say, what is health equity? And we at Deloitte believe that it's a fair and just opportunity for every individual to achieve their full potential in all aspects of health and well-being. And that without equity, that there are disparities, which are the quantifiable differences in health-related outcomes that exist among different populations based on race, gender, location, disability status, that are truly preventable. And Dwayne, as you mentioned, I think it's always important to highlight the economic impact and the financial toll that racism and bias and health inequity has, which is $16 trillion of opportunity cost over the last 20 years. Specifically, avoidable healthcare spend that Kellogg Foundation has said, could reduce over 135 billion of spending in healthcare if we could just close the gap on healthcare disparities. But while these numbers are significant, I would stress that the real imperative for health equity is the human impact, right? We've seen what COVID does. We've seen Black and Hispanic Americans being twice as likely to die from COVID. We've seen life expectancy for African Americans drop by almost 3 years over the last year. We've seen that low-income Americans are twice as likely to die from stroke and chronic disease than wealthier Americans. That 50% of individuals living less than 2 miles from a toxic waste facility, which are linked with issues such as cancer and kidney failure, are people of color, and that our lesbian, gay, and bisexual youth are twice as likely to attempt suicide than the non-LGBTQ peers. But given all this data, we are in a place, I think, as business leaders where we can stop admiring the problem and actually do something. And I want to talk about what are some of the actions we can take to do that. But before jumping into that, maybe a minute on what are the root causes of health inequities. Now, we believe strongly that racism and bias work their way into the healthcare ecosystem at many levels, where facilities are located, how physicians are trained, algorithms that direct resources to one group versus another. Independent to racism and bias, we know that the drivers of health are factors that lead to health inequity, and some refer to these as social determinants of health. We think that these are independent and also multiplier effect with racism. And then there's actually significant research that shows that racism itself can have its own negative impact, and that people who've experienced more racism have a higher risk of chronic inflammation and chronic illness. And so while each of these factors is important to understand and address, it's also critical to understand the multiplier that each of these have. So enough lecturing, though, to a group that is already very well versed in this topic about what it is and what the root causes are. I'll spend one more minute saying, what can we do? And we at Deloitte believe that there are really 4 domains that business leaders can take action. One is within the organization. So how do you get your own house in order with your talent pool, with how you're treating those and how you're addressing the needs of drivers of health within your own employees? It's looking at offerings and services and making sure that they're equitable. Operational hours actually address the needs of different groups, and that the products and services aren't biased to meeting the needs of one group or another. We're not using race-based algorithms to provide care. It's looking at community to say, what are our strategies to connect with non-clinical organizations, non-healthcare, to foster public-private relationships? And then finally, it's the ecosystem play, which is what's most exciting to me about this conversation, is that you have private sector, public sector, not-for-profit sector, government agencies all coming together to say, how can we actually collectively have an exponential impact in addressing health equity? So that's a lot in a short amount of time. And Dwayne, I'll hand it back to you to say, I'm truly energized and excited to be on this journey with this esteemed group and many of our audience who are working tirelessly to advance health equity within our society.
I am too honored, and thank you, Kalani, for kicking things off, and thank you again for sponsoring the event. So I'd like to go ahead and get started, and I'd like for you all, given your diverse backgrounds, to set the stage for us and share what you see as the challenges driving health inequity and obstacles to health equity. And I'd like to start with Mr. Watts. Bobby, given your role on the COVID-19 Health Equity Task Force, can you share some of the immediate issues you're grappling with and how your work as CEO of National Healthcare for the Homeless Council informs your discussions?
Certainly, and I just want to echo what an honor it is to be here with this audience and such an esteemed panel. I can share what is been shared publicly around the work of the task force, and we are looking at on a few levels. One, we're looking at some recommendations that we can make right now, and then later we will be looking at recommendations that should be implemented in the future to prevent some of the crises that we experience in the next pandemic. So we've looked at a few each month. We look at a different area. We have looked at vaccines. We have looked at behavioral health, both mental health and substance use disorders, the impact that COVID has had on exacerbating disparities and inequities there. And right now, this month, at our upcoming meeting on June 28th, we'll be looking at making recommendations around the area of discrimination and xenophobia. And I will just say, from my perspective, working for 30 years with people experiencing homelessness and trying to meet their healthcare needs, one of the largest, the perspective that I bring of our community of doctors, nurses, and people with the lived expertise of homelessness is the importance of housing as a social determinant of health. Of all of them, that is probably one of the greatest. In your intro, and we've heard wonderful from the sponsor talking about geography. And we've all heard that your zip code determines your health status more than your genetic code. And there is so much in where people live that affects their lives. And so much of that is driven by systems that have inequity baked into them. So we really have to address them if we're going to achieve health equity in the short term, as well as in the long term.
Thanks, Bobby. I'd like to come back to you for more on that and some tactical solutions we can employ there. I'd like to turn it over to Dr. Morita. You have significant experience developing and implementing programs at the local level, especially targeted at immunization. And you've been a very forceful advocate for COVID-19 vaccine equity. Can you shed some light on some of the challenges you saw in your previous work in Chicago and that you see now that are driving health inequity and the obstacles?
Yeah, thanks so much, Bobby. Dwayne. I was just reflecting on Bobby's comments as well because they're so salient to this conversation. But so in my prior role as health commissioner and as medical director in Chicago's Department of Public Health, we were responsible for leading the H1N1 vaccine distribution program in 2009. And we learned a lot of lessons through that process because what we saw playing out there was somewhat similar to what we have seen play out with COVID-19, in that we were pushing to get the vaccine out and distribute it as broadly and quickly as we could. And we quickly saw that it wasn't really reaching our communities of color. And they were also being hit hard by the pandemic at that time. And so what we did is we worked to engage with community organizations to try to get them to help us to drive demand within the communities and also to make sure the vaccine was as accessible as possible. And we had mild to moderate success with that. But it was really what was helpful about that experience is that we recognized that trying to engage community organizations in the midst of a crisis is not something that's highly effective. That in order to really engage with community and have community being part of the solution making, you have to establish relationships early on and in times when you're not in the middle of a crisis. And so Chicago learned that lesson and actually worked very hard to establish community group connections in public health planning, just at baseline. And so from 2009 through the pandemic, this last year, there was a lot of engagement with community organizations. And so when the pandemic struck, Chicago had these relationships already and were able to mobilize these connections to do contact tracing, to do testing, to help with vaccine distribution, to make sure that it was more equitable overall. And so there were critical lessons that were learned in that crisis that helped us to then ensure that the process in moving forward was more equitable. But it wasn't just about, it's really taking into consideration access in terms of how accessible are the vaccines? Are they located in places where people can get them easily? Are they, you have to have high-speed internet to make an appointment, or can you call up 24 hours, 7 days a week to make an appointment? Are the clinics open after hours or on a weekend so people can really access the clinics in a way that works for their schedules? Because not everybody has access to paid time off or a vehicle to get to a particular place. So it's really critical for us to be working with communities, engaging with communities in peacetime, in times of calm, so that when the pandemic arose, this last time, that people were better prepared. I still think there's a lot of work that needs to be done, but this concept of engaging with and working with communities so that they're part of the solutions is really essential for us to really address this issue of health equity.
Thanks, Dr. Morita. Pat, I'd like to turn over to you. I mentioned earlier about how geography matters. Bobby mentioned your zip code matters. Can you shed some light on the challenges facing the rural population and some of the rural risk factors that lead to the inequity we see today?
Sure. Yes, obviously rural is geography. You look at 80% of the country is rural, and so that brings its challenges too. And I appreciate rural being part of the equity discussion, because so often, we have the pockets of racial and other disparities, but we also have rural as far as resources and where you live, transportation, and in many of our communities, we have prisons located in our small communities, and that brings an example. We have a lot of food packing and meat packing plants that have some racial areas that really lend some challenges in getting healthcare to them. That's very, very important. The other thing is resources, that you have in rural communities. Not every community has a physician, not every community has a hospital, and we've lost 136 small rural hospitals in the last 10 years. And when you do that, some places they have to, instead of driving 25, 30 minutes, they may have to drive 60 to 90 minutes. And you talk about delivering babies, you talk about just getting simple care. we can talk a little bit later about solutions with telemedicine, but we do have our challenges because of transportation availability, geographics. There's many wonderful things about living in a rural community, but there are challenges, and they vary from, you've got Maine, you've got Alabama, you've got Wisconsin, you've got Illinois where I live, and the West Coast, and each of those rural communities bring different things because of climate, because of travel, and so forth. And so as a community, you have to be responsive. And in the past, rural has sort of been left behind, because it's not as big a population. It has been, it's 20%. And so we have to bring that a conversation. We have to bring the health equity issues as far as what was just mentioned by my colleagues, but also the resources and availability of funding and payment and economics of jobs and so forth to keep people sustained.
And I'm glad you mentioned that.
Poverty.
Yeah, and we discussed previously about issues affecting rural Illinois, rural Maine, rural South, and a lot of the solutions can be very different based on where they are. So thank you for mentioning that. Dr. Ree, you recently joined CVS, and CVS has a major role in our healthcare ecosystem as a payer, but increasingly a growing influence of retail pharmacies in providing access to care and ensuring continuity of care. What are some of the main challenges you see that you're working to address?
Yeah, no, thank you for having me, and thank you for being part of this amazing panel. I would highlight this three big broad words as we've got to address health equity and topics like vaccine equity: access, trust, and then health. And I'll go a little bit deeper, but at CVS, we're so proud of the fact that 70% of Americans are within 3 miles of a CVS, 90% of Americans are within 10 miles. And the issues of access are important there. We've supported an extraordinary number of telehealth visits, as we know, in this pandemic. There's so many things that have accelerated and transformed and that will evolve into the new normal. So, providing access through telehealth, for example, 65% of our mental health visits are provided through telehealth. There's extraordinary opportunities there to increase access. And we're proud of the fact that we've delivered about 17 million plus vaccinations and 23 million tests for COVID, which represents 70% of the retail testing. As you can imagine, if you've got symptoms, you're going to want to make sure that it's not something you would spread. So access is an important piece of our strategy as we think about the future and the role we can play. But ultimately, it's the second piece about trust. It's about the team. And we do believe this is the year of the pharmacist. There's an extraordinary role that the whole team plays. As a primary care physician myself, my first job right out of residency was a National Health Service Corps scholar in Columbia Heights at the corner of 14th and Irving. And right across the street was a CVS. And that team at the CVS, that group of pharmacists and pharmacy techs, are playing an extraordinary role during this pandemic. 50% of our pharmacy techs are non-white, 40% of our pharmacists are non-white. And I would suggest that aspect of trust and making sure your workforce represents the people you serve plays such an integral role in addressing issues like vaccine confidence, vaccine equity, vaccine hesitancy. And that is why 34% of our vaccinations, of those 17 million plus, are from underrepresented minority groups. It's from Black, Hispanic, and Native American communities. So trust is going to be a very important component. And to me, if you're in the community, just like I trusted the local CVS pharmacists and pharmacy techs when I was working as a primary care doctor across the street, that's an important ingredient as we move forward, because so much of trust can be built virtually, but a lot of it does require a face-to-face interaction. And I do believe that that's going to be important with the amazing nearly 10,000 sites we have across the country. The last piece I want to highlight is that we've realized that health is so much more than healthcare, and this pandemic has emphasized that. And I like to use the acronym when I was a commissioner at the Robert Wood Johnson Foundation for a healthier next generation. I use the acronym HEALTH: housing, education, access to healthy choices, labor, transportation, and healthcare. And so health includes healthcare, which is necessary, But ultimately, you have to think about the challenges of affordable housing. We've made a commitment of 600 million to address racial equity over 5 years. Much of those investments are around affordable housing. Education, we know that part of the challenge is our workforce is not sufficiently diverse in healthcare. And so there needs to be more diversity. And then access to healthy choices. We gave up tobacco 5 years ago. And then, of course, employment. We need to help give people jobs. 115,000 people have moved from public assistance to CVS careers. And then transportation, partnering with Lyft to provide access to things like getting a ride to get your vaccine, and then healthcare through our low and no cost minute clinics. So many opportunities across all those areas: access, trust, and health.
Thanks, Dr. Rhea. I know we'll come back to those key points as we talk about some of the next steps to addressing some of the issues we're facing. I'd like to turn it over to Kevin. Johns Hopkins, on the front lines of our COVID crisis, you had the task of addressing the health and well-being of patients you serve, but also of your staff. Can you share with us some of the longstanding issues that you see are driving health inequity and how they may have been magnified by the COVID crisis?
Yeah, Dwayne, thank you so much for having me as a part of the panel today. I appreciate the opportunity. I began my career as a nurse, so I come at this from a very different perspective and a frontline perspective in terms of understanding the implications of health equities. And so when I first came to Baltimore, I was at Duke for 32 years and came to Johns Hopkins about 3 years ago. I was given a book, and the book was entitled Not in My Neighborhood. And it was an important lesson that as you come into leadership roles, it's important to understand the history of the communities that we live in and that we serve, because it's that histories that have driven some of the social determinants. In this particular book, it highlights that during desegregation in this country, there were 2 cities in the nation that got away with continuing to allow segregation through real estate laws, through redlining, and not being able to sell housing to certain populations. And if you think about the issues that Baltimore faces and St. Louis faces, they're very similar. But as I think about that and the implications of what took place during that time, it was a social experiment that went really bad and created communities where there are social determinants that were driven by many years of decisions that were made that were not fair or were not equitable. And I want to go back to some of my colleagues' comments. As I step back, this has created issues around access to quality healthcare, access to quality education, the environments the folks live in and socialize in, fiscal health, our relationships in these communities. And what we've seen during the pandemic is that these communities that were impacted by historical decisions were impacted by COVID much more at a higher level, and also the implications of job losses and also the issue of school closings. So as I look at what part of what we faced with our own staff, and I'll start with our own staff, many of our frontline workers, entry-level positions, had often 2 jobs and they lost 1 job. And the biggest thing they were faced with was an issue of being able to put food on the table. So in each of our hospitals and our ambulatory care clinics, we develop food banks for our own employees. We also recognize that in the community we serve, putting food on the table in many of our families' households was an issue. So we partner with a food distributor and have now served close to 8 million meals since the beginning of COVID to our staff and also to the citizens in East Baltimore, because that was a part of health and well-being. Now, I got to be honest with you, that is not a new phenomenon, but I would say that this heightened the awareness of the implications of that. We also developed a fund to support our employees who were unable to pay their rent or unable to pay their light bills. And we also bought computers for some of our employees who could not afford to have computers for their children at home for homeschooling, and also purchase Wi-Fi in their homes. So there was a lot we did around supporting our workforce that were really driven by zip codes and by social determinants that were pre-existing prior to the pandemic, but really heightened our awareness of how we needed to support. In our community, it was heightened because we used data to really inform our decisions of where we needed to take our approaches and support our community. There is an area, several zip codes in Baltimore, where we have a significant Latinx population. And so we specifically went in and partnered with the Catholic Church to set up testing sites. We've now done mass vaccination sites there because at the beginning of the pandemic, we saw a 30% positivity rate in those zip codes. We also opened the Lord Baltimore Hotel as a place to quarantine people because we know from a cultural standpoint that it's not uncommon to have multiple generations living in one household. And so we tried to look at a systematic review of how to make safe environments for the citizens that lived in that community. We also went into partnered with Housing Authority and the Public Health Department looking at vulnerable population, and that was seniors living in senior housing units. And having personally gone in and vaccinated in those units, I saw patients who would never make it to a mass vaccination site, never be able to make it to a pharmacy because of the mobility issues they face. And it really reframed for me, do we need to address health equities in a different way by taking services to them versus requiring them to come to us? And so I think that was a personal insight that I really have gained by going and out and actually looking at the health and well-being at a local level. I would also say that we realized we couldn't do this alone. And so we partnered with University of Maryland, our city and our state to develop public-private relationships that allowed us to partner together to better serve our community. Because if there was ever a moment in our history, the moment was now where we really have to think about how we come together to serve our communities. And it wasn't about competition. It was really about meeting the needs of the people. I'll just close by saying there's a quote by Dr. Martin Luther King that reminds me of some of the things we face and some of the things we're talking about. And he talked about an inescapable network of mutuality. And if there was ever a moment where the points of connectivity was important in our community, we were all impacted, and some people impacted in very different ways. But at the end of the day, it took us coming together to serve our communities. So thank you, Dwayne.
Thanks, Kevin. And Dr. Sabah, I'd like to turn to you. And if folks want to jump in, go ahead and raise your hand, because I'd like to discuss the important piece of this that was mentioned earlier. Dr. Rhee, I think you mentioned it regarding diversity. Inclusion and diversity matters, and Medtronic has been doing quite a bit of work in this space. So I was hoping you could lay the foundation here and give us some of the challenges you see of trying to implement some of these programs, but also give us a flavor for what you're trying to do and some programs that Medtronic is supporting.
Absolutely, Dwayne. And I just want to echo my fellow colleagues here. It's a pleasure and an honor to be on this panel. But I also want to recognize Deloitte for actually bringing this conversation forward and the work that you're doing to lead in this space. We all know that health inequity is not new, and it's not US only based, it's a global issue. It's been one of the 6 aims of the Institute of Medicine for a very long time. It just has been the probably unforgotten child, the kind of forgotten child for a while, until 2020 really exacerbated and put a spotlight on this issue. And therefore, we're now coming collectively to really address it in a more collaborative and meaningful and insightful way. The World Economic Forum issued a couple of years ago articles around the rise of the social enterprise. We align with that thinking very much, which is that it is no longer okay for organizations to only focus on their bottom line. organizations need to be involved in societal change, and that's an expectation of talent, and it's an expectation of your own employees. So within that framework, and this wake-up call that we've all had in recognizing that social, political, and economic issues don't kind of be left at the door. Your employees are these issues, they bring them in, and companies are needing to work through them and have a voice and a purpose in delivering against societal change that is meaningful. So for Medtronic, we always anchor in our mission, which is to alleviate pain, restore health, and extend life. And that's linked to one of our other tenets, which is the recognition of the personal value of every employee and every person. So we have a construct for our inclusion, diversity, and equity agenda, which we drive as a business strategy. So it's not a program, it's not an initiative, it's actually one of the key priorities of our CEO. And we constructed it in a framework that's very similar, Kalini, to the framework that you were describing earlier on in this conversation. We have centered it around three main elements: the individual, so each of us being a role model for inclusion and diversity; our company, how do we institutionalize the elimination of bias throughout our organization? You can't really achieve equity outside unless your insides are really matching up to that as part of our belief. But our third one, which is the one I'm going to focus on here, is amplifying our impact beyond Medtronic. We have four key areas there that we have crystallized and really defined in this last year. The first one, which is often forgotten, is supplier diversity. It's that economic impact. How do organizations use the power of their own purchasing power to really make an effect in their communities? Because wealth and health are inextricably linked, and economic impact creates jobs and therefore enables people to have better access to health. The second one is diversifying in STEM, in science, engineering, and math, and so forth, because we also know that that is an area that still has many challenges. We need more physicians who are from our communities of color. That those systemic effects that have caused the imbalance there are things that we are targeting. The third one is healthcare disparities, and we are leaning into diabetes as an area of focus for us, given where the portfolio of our work right now, and we're doing that in partnership. Our CEO was just talking at a global town hall yesterday, saying almost every customer he has spoken with in this last year has talked to him about how do we partner on health equity. So it is coming forward as a conversation that's meaningful. The fourth area is influence. We all as companies have influence and have the ability to create partnerships, to sign up on policy change, to affect change on a global scale with the power of our voice, like the Business Roundtable and otherwise. And we've really leaned into that this year in many fronts. But lastly, Medtronic, of course, as a global med tech company, we also believe that technology can be a real propeller for eliminating health inequities at large. A mom who has to hold down 2 jobs doesn't have the ability to take time off to go and get her preventive screening for colorectal cancer, can swallow a pill now and get that done from home and not need to take the time off to go and do that. But also we have a voice in policy. Are people getting access to time off in order to access preventable care and so forth? So just an example of the types of things we think about and that we are leading through.
Thank you. And I know there are some hands raised, but I'd like to get Dr. Maybach in here first. And the timing of this is we're fortunate because AMA released its strategic plan to address health equity. And I was wondering if you could give us a read into that and lay out some of the recommendations. And then I'd like for folks to provide some feedback there.
Sure. Thanks. And thanks for having me on this panel. And great to be in a community with many of the folks on this panel that I know in many different ways. So hi to all of you. So yes, we just released our plan. We've been working on it for the last 1.5 years as the Center for Health Equity, which has now been around for 2 years. which was a movement by our House of Delegates to make sure that we formalized our work as the American Medical Association. For those who don't know that is, it represents a certain amount of physicians, 270,000 across the country, has lots of experience and power, I guess, in the space of advocacy in this country and in other areas as well. And so the House of Delegates really felt, it was very important for the American Medical Association to have a more strategic and intentional way of moving forward. And I think that's the important part of equity work, as I know everybody on this panel knows, is that we got to move beyond the words and what are the actions, how do we lay them out, and then how are we going to measure them, and how are we going to hold ourselves accountable to actually doing what it is that we're going to say or that we said we're going to do. And so in this plan, there are 5 strategic approaches that are outlined. However, I think also really important for me is that we wanted to take the time to make sure that we were educating. It's an 80-page strategic plan. Most strategic plans are not 80 pages long, and we're very well aware of that. However, also have to be well aware of where the environment is and where people are and where physicians in the healthcare community is, and understanding concepts around equity, whatever it is. Whether it's racism or the social determinants of health or structural drivers. So we wanted to use that opportunity to really kind of shape and frame, the history of health equity as a field and a space, and kind of the concepts, and lay some grounding so that we could have some building of having a shared analysis around these words, because narrative is really important. Words are important. Words shape the narrative. Narrative shapes and determines actions. And it also shapes and determines responsibility and frames responsibility of who should be at this table as we speak about the ecosystem being involved in solutions. Oftentimes, our narratives that are dominant actually hide responsibility and kind of shift blame to other spaces and places. So, we talk about the technical parts of the work, which I'll get to in a second in terms of our strategic approaches. But I think it's just really important to highlight, especially as it goes to, working together and being at the same table, these narratives that, and really they're narratives within our country that are historical, that was mentioned by Kevin earlier, about, individualism and this focus and then this belief that for some reason, all this work is ahistorical and not historical. The myth of meritocracy, the myth of a zero-sum game, the limited future orientation, American exceptionalism and the myth around that, and the myth of white supremacist ideology, or at least the myth of the value of hierarchy based on whether it's skin color or gender or sexual orientation. All of those things are critically important. Where you live, as was mentioned before, there is a hierarchy and there's a value oftentimes that's assigned to people and communities, and it's structured in our policies. And I think this opportunity is, I don't think we can leave that part of the conversation, and I will continue to push that conversation. And I think, because folks will say, well, why are we going to talk about that? Business people don't want to talk about that. They're not there yet. Okay, that's fine. But people weren't at the point of saying racism really until this summer with the public murder of George Floyd. So I think it shows that, when you do start to present and share information, show people's lives, I think that was mentioned earlier about, this is about people and humanity. When we start to get to those stories, you actually can change hearts and minds to do something differently. And I'm seeing it happen at the AMA, which is historically known, to be it was an exclusive organization, and it still lacks a certain level of diversity. But I have seen people move. And I've seen people do their work. And I think that's an important part of this work when we're leading, of doing that own personal work of self-reflection, of how we're showing up as individuals in society that are leading institutions and organizations, or else this is not sustainable. It's just not. We can have great and good intentions around it, but I don't think it's sustainable. So to get to the points of the strategies in the plan, and I was really happy. So Kalani, what you mentioned in terms of the work of Deloitte, I was writing them down, and what I realized in doing this kind of cross collaborative work, and it played out when I was Deputy Commissioner in New York City Department of Health, when we would sit down with planning or transportation, we had just completely different languages. We just talked about things in different ways, but we were actually saying the same things, but it took some time to kind of figure that out. And so as you were going through your plan, I said, wow, those are it's really similar to kind of what we're doing in terms of your framework. And it's actually not a framework that I typically hear from the business sector in terms of starting with the inside out. So our first strategy is about embedding racial justice within our organization, and not just racial justice, but at the intersection. We have a race and approach, understanding there are all four types of oppression that exist. But again, we can't do equity work on the outside of our organization if our own teams and staff don't even understand how to define it, the concepts around it, how their own actions and decisions can exacerbate inequities, or maybe even advance them. So there's a whole body of work of the internal parts of doing this. And this is the part that I think a lot of institutions haven't quite fully embraced and grappled with, because that means there's not only like the collective reflection, that means there are individual leaders that are going to have to reflect. And that's hard work for people. And that's where we can get a lot of resistance, but we're moving forward in that direction. The second part that we're doing is around building alliances and sharing power. Again, it's just a different way of framing the work of saying we need to center the voices and ideas, experiences, and people who have been historically marginalized from these decision-making processes to create solutions that many of us have, again, great intentions to do for the communities that are being served by our companies and institutions, but oftentimes they're completely left out of the decision-making, not only in our employment space, but just even in our engagement space. And so how do we do that better across the board?
And Dr. Mavick, maybe I'll have Kalani jump in, and she raised her hand as you were speaking, so I want to have her respond.
Okay.
No, I mean, Dr. Maybank and you and I think almost every person on this call I've had some interaction with on this professional and personal journey to advancing health equity. So I really appreciate your words on how it's all linked. And I failed to mention this at the beginning because I was so excited and looking at everybody's face, but I think that the organization part of it is so critical. And we as Deloitte have actually set up a Health Equity Institute, which is very similar to the, it's a way of just organizing and coordinating what we do. And I'll give you this, Dr. Maybank, before I hand it to you, which is 3 parts to it, right? Which is, how do we actually partner with ecosystem players to do more, right? How do we use data and insights to drive action exactly the same way that you're describing? And then the third one is, how do we actually democratize the lessons learned and the knowledge so that it doesn't belong to a single institution or a single part of the ecosystem? So I really appreciate how aligned we actually are.
Yeah.
And Dr. Maybank, if you want to just spend another 30 seconds talking about your next steps, you can have the other panelists jump in as well.
Okay. And so lastly, I would say the one that has not been mentioned enough, it was touched upon in terms of looking at the historical context, but fostering pathways for truth, racial healing, reconciliation, and transformation for our past and causing harm. The reality is that the majority of historically white institutions in this country, whether historically like old historically, or within the last couple of decades historically, have some type of relationship oftentimes with the neighborhoods and the communities that they're serving that have not been beneficial to the communities that they are serving, and have caused harm. And so what do we do to repair that? How do we name it? How do we elevate it? And so, in this document, we do take some effort to start naming some of those past harms. And I mentioned one before in terms of the exclusion of Black physicians. We've apologized for that for sure, but that's not quite enough. We need to quantify and qualify what are the costs of that harm, and then what are we going to do to repair it? And I think that is the front movement of health equity work. We see that these conversations starting to happen amongst our federal administration and some of the advocacy that has been happening. But we want to make sure we push forward and recognize our role and responsibility as a large, old-standing organization, as well as a healthcare organization, to do better.
Thanks, Dr. Maybank. Dr. Morita, would you like to jump in here?
Yeah, well, thank you so much. I think alignment is really the key word here, because what I'm hearing from each and every one of the speakers and the panelists is that we're talking the same talk. That basically there's internal work that needs to happen, and there's also external work that needs to happen. And I think what the COVID pandemic and the racial uprisings that we saw last year have made clear is this deep connection between the structural inequities and health. And so where the Robert Wood Johnson Foundation has been speaking about social determinants of health and health equity for a decade, health equity has become now a household word where people are talking about it and they actually understand that we're talking about lack of access to good jobs with fair pay, lack of affordable and safe housing, lack of childcare access, lack of access to good nutrition, lack of paid time off. Those kinds of things are all now being clearly linked to health in a way that we have not done that in the past. And so I think I think Einstein has said that with any great crisis, there is great opportunity. And I think these crises that we've experienced recently have really lifted up the opportunities that we have to make a difference. And for Robert Wood Johnson Foundation, what we did is we looked back at our work last year, in the beginning of last year, and said, is this work the most important and critical work for us to be doing, focusing on determinants of health, focusing on health equity? And we said, yes, indeed it was. Looking at these upstream factors for health and addressing the policies and system changes really are essential to addressing health equity overall. And what emerged more clearly toward the end of last year is that our work increasingly needs to focus on and be explicit about structural racism as it relates to health. That we can't really talk about health equity without acknowledging structural racism as a pathway to addressing structural racism as a pathway to achieving health equity. And so we have to commit to doing those things. And so the foundation's focus on economic supports, whether it's tax credits or nutrition supports, or our focus on the environments that people are living in, whether it's housing or whether it's environment, or whether it's structural racism in the healthcare system. Those are the areas that we've been focusing on and will continue to focus on because we recognize the impact that they can have on health overall at baseline, and then to help us be better prepared for the next pandemic. Because the last thing that we want to see happen during the next pandemic is what played out with this COVID pandemic, because that could have been avoided had we been more successful in addressing health equity overall. So I think what gives me hope about the future is that we see the American Rescue Plan, which includes many critical elements that are beginning or a start to addressing health equity, whether it's economic tax credits, support for caregivers, nutrition supports, housing supports. There's elements that can really be built out and enhanced to make us a more equitable country overall in the future. So there are elements in place with the rescue plan, but it has to be supported. It has to be advocated for by a cross-sector, public and private partnerships to really lift up these kinds of supports so that we really are better overall in the future. So I think we have this opportunity, and I don't think we want to miss it. And I want to acknowledge too the importance of this internal work, because RWJF is also going on this internal work, looking at how we're doing in terms of how we're managing our staff, how we're handling our grant making, the work that we're doing and how we're doing it to make sure that we're not perpetuating structural racist practices as well. And so I think we have insight into what we need to do, and now it's enough. It requires us to all work together to really to effectuate this and to make it happen.
Thanks, Dr. Marita. And Dr. Ree, would you like to jump in here?
Yes. Look, I resonate with everything that's being said and the importance of structural racism. And I mean, thinking about my daughters and, the challenges that the Asian American community has suffered and Asian hate that I've suffered my whole career, there is a moment here that we could create a real movement. So I just want to emphasize that. I do want to highlight as a term that I believe strongly in, that's the concept of tequity. So the traditional scientific evidence has been health disparities, and health equity is so exciting to now find relevance and talk about things like structural racism. But how do we leverage technology during this pandemic to advance equity? And with Meharry Medical College, we published a whole supplement when I was previously at IBM that just came out early May of this year, and it highlighted 4 key components to the panels have highlighted this. The workforce. The first one is the people. Look at yourself in the mirror, look at your own team, look at the people that are on these Zoom calls and how diverse is that team. And I've often experienced my whole career, often being the only non-white person in a lot of meetings and rooms where important decisions are being made. And so once again, the importance of the belief that I believe strongly we're a country of immigrants, and diversity breeds creativity, and you need innovation to address the crises like inequities. And so how diverse are we? And at CVS, we're very proud that we've created this transparency about the diversity of our workforce. across, annually and reporting it at different levels, at VP and above, the board, et cetera. It's so important that companies and organizations represent the people they're meant to serve, not only today, but as they look to the future. Number two is data trust. And so to leverage data, I'm very concerned about the issues of trust that we're highlighting that have been around for centuries. And how do you appropriately think about that data and collect it in a trusted way with those trust brokers? And you can't talk about which lives matter if you don't know which lives are which. And so it's so important that data is collected in a trusted way. And you have trust brokers like community health workers or pharmacists or other groups to collect the data, like country of origin. I get disappointed that I'm put into the same category as other Asians sometimes, where my children and others get called Kung Flu, or, frankly, they're not accurate. I'm Korean American. I'm not Chinese American. And so how do we start thinking about the issues of data and trust and collecting the data as we look at that data to make decisions now? Because we want to translate that data into the next piece, which is dashboards that include equity. Equity was the Rodney Dangerfield of the healthcare quality measures: safe, timely, effective, efficient, patient-centered. Those all got all this attention, but equity has not. To make a movement to make sure equity dashboards are standard and they're transparent. The last piece is just the importance of transparent and ethical and equitable AI. The reality is AI is part of everything we do right now in retail and other settings, and we could inadvertently worsen disparities if we're not careful. And so being transparent about the AI, we've got over 700 data scientists at CVS Health. We've been very proactive about thinking of population that we're building these algorithms for are represented in the data and the training, et cetera. So it's so important to think about workforce, data trust, equity dashboards, and transparent ethical AI.
Thanks, Dr. Ree. And Pat, I'd like to bring you in here on this issue of technology. There are access issues when we talk about rural areas. Folks who are in urban areas may have access to technologies that people in rural areas don't. Can you highlight how you're trying to overcome some of those issues when we are moving towards embracing more technology?
Right. Within the rural communities, technology, the pandemic has really helped us move forward with using virtual. We've used a lot of USDA grants and other things to help make sure that we get that last line of broadband into these rural communities. But it's having to do some education with the senior community, with people that don't have access, they don't have computers, of getting funds out to them and really helping it. Because communication is really key within the community of getting the word out and knowing about access. I just wanted to add a couple of things about rural. It's really about community. We have some rural communities are very homogenic, as you might know, very agricultural farming, and then we have some that are very diverse. And so what we've tried to do within the rural collectively across the country is really look at culture, our population health, and outreach. Somebody mentioned earlier is getting out. Instead of people coming to us, how do we get out to that and to better understand it? So that's our challenge, what we're doing internally with rural. And we're very carefully assessing the rural divide. And how do we make sure that we have access and communication? And how do we communicate back and forth with social services? How do we get food banks to us? How do we deal with those issues? Because that's very, very critical. I could talk for a while, but I think my colleagues want to say something too. But rural is very, it has its equity because we have a higher incidence of cancer, cardiovascular disease, accidents, and all of that. And you have to take into consideration the importance of access as well as diversity, and help us to better understand the culture through our outreach and digital elimination of the divide.
Thanks, Pat. And Bobby, if you can spend a minute, since we're running short on time, you wanted to jump in here, but wanted to ask you about the technological aspects and how that may help bridge the divide or may worsen it.
Sure. I'll address that quickly, and then I have one other comment. In healthcare, one of the most important things we talk about social determinants of health. One of the strongest social determinants of health is housing status, and it is rarely asked at the point of care whether someone is, what their housing status is. And I have asked, and I can't understand because it can't. I've asked this question: how can you, as a clinician, be sure that the care plan that you've developed is appropriate if you don't know the housing status of your patient? And the answer is you can't. So there are many electronic health records where that field is there, the Z59 codes, the Z codes, but we're not asking that. And really the leaders of healthcare institutions, leaders of state health departments, if we want to advance equity, we have to start collecting that data around housing and other important social determinants of health. As someone has said, the lack of data is oppression in and of itself, because we can't disaggregate, we can't monitor, and then therefore we can't attack. The last thing I want to say is that in healthcare, we do a really poor job of listening to our customers, probably worse than any other sector. And I just want to say a word about inclusion, and that is really one of the strengths of the National Healthcare for the Homeless Council. We have people who have lived expertise of homelessness on our board. We want that to be in each of the 300 federally qualified health centers that focus on people experiencing homelessness. And all that we're talking about achieving equity, we can't do it without true inclusion. And inclusion has been defined as, someone said, diversity is getting invited to the party, inclusion is getting asked to dance. And I say, no, inclusion is getting asked to help to select the playlist. So until we are really listening to those that we say we're serving, we will not, we're not really serving them well as we could, and we won't achieve equity.
Thanks. And Kevin, I'm going to give you the last word here. Can you share your thoughts on how Johns Hopkins is incorporating technology in some of the innovative ways hospitals can bridge the gap here?
So it's one of the things I wanted to highlight, Dwayne, because I appreciated what Pat said about rural, but I also want to highlight that in urban city settings, there are parts of our community that don't have broadband. So it's just not a rural issue. It is also an urban issue. And during the pandemic, we were doing about 6,000 telemedicine visits a day, which really served us well in certain populations in terms of disease states and or follow-up post-surgical or procedure. It's not for every type of visit, I would say. We learned that psychiatric intake for the first visit and not the best use of telemedicine, but also I would say that as I look at dermatology struggle because of the images that you can examine during that time. So I don't think it's going to solve all of our problems, but for primary care visits and other things like that and consults, I think it's very appropriate. But the problem we had is we couldn't do it for everyone that was a Johns Hopkins patient, because not everybody had access to Wi-Fi. Many people had flip phones or had burner phones. So the economic impact of what people have access to really created a chasm with the technology piece. We also now do a lot of home telemonitoring on different types of equipment. We are sometimes limited as to who can have access to that equipment based upon what they have in their home and our ability to telemonitor. So we have got to address as a country the issue of having access to broadband for all parts of our country and not certain segments if we're really going to use technology as a major piece. I was reminded we were first setting up the ability to get a vaccination, and we happened to be on Epic. And in Epic, there's a component called MyChart. And in MyChart, you can go in and schedule your own appointment. And there was a group of people saying, well, that's how we're going to schedule people. We'll have people go into MyChart. And I said, well, what about the people who, number one, don't have access to MyChart, don't have Wi-Fi in their home, and have no idea how to use MyChart? So what we did was we looked at our high-risk communities and we set up call centers in the community where you could either call and schedule your appointment, or people could walk in. And if they had access to the technology, we also had someone there to train them on how to access MyChart. And so we used it in multiple ways, but we put it once again back in the community so that they could have that connection in the community in which they lived. But I think there's some structural issues we have to address if we're going to have equal access in this country for technology solutions in the delivery of healthcare.
Well, thank you for that, Kevin. I wish we had another hour to continue the conversation because there's definitely a lot to say. This is the right time to be talking about this, and we definitely gathered the right people to have this conversation today. And I look forward to continuing the conversation. So thank you all again for your insights. Thank you to Kaleni for the view from Deloitte, and thank you Deloitte for sponsoring this event. Again, thanks to the panelists, and we'll send you the event highlights article once it's complete. And again, thank you to Deloitte, our sponsor today. Really appreciate the conversation, and everybody stay safe. Take care.